Thank you, Mr. Chairman. Very important hearing. I do apologize I wasn't here to hear the testimony from the first group here, but thank you each for your contributions in this area. As my colleagues know, Alaska's pretty rural. In fact, Alaska is so rural it's bush. 80% of our communities are not accessible by road. So much comes in by mail when we think about the drugs that impact our communities. And I want to ask about drugs that come in over the internet. But the first question was raised in a meeting that I was in just this week with providers that serve our rural areas, and it was as it related to the medical-assisted treatment and how these are administered, whether it's Suboxone or others. It's our understanding that the prescribing provider is required to be physically in the room with the patient. Well, in far too many of our rural communities, we don't have that provider. We do so much of the care by distance delivery. You've got a health aide that is administering, but the question that was raised with me is whether or not there is any kind of an exemption option or a waiver option under the Ryan Haight Act that would allow providers to prescribe Suboxone through telemedicine to these individuals that are in highly rural communities, bush communities. Is there a way that we can use these technologies to help in the event of an emergency? Do you have anything that you can offer me? Dr. McCants.
Yes, thank you, Senator Murkowski. And so here's what I would say about that. While I don't have the Ryan Haight Act at my fingertips, I believe that what it requires is a valid physician-patient relationship, and that is generally characterized by at least one visit face-to-face where there is an examination that's done, a diagnosis that is made, and a treatment plan that then follows. But afterwards, I think telemedicine can be used, and it may be possible that we can work with DEA around the issues of whether we can have, in a telehealth kind of setting, a provider who has done those things and can work with a waivered provider who might be in a distant place. So those are the kinds of details that, to my knowledge, have not yet been worked out, but there is already precedent for telehealth where a provider is distant and can work with another practitioner who is actually seeing the patient in a community. So that model exists. What doesn't exist and isn't well defined yet is the issue of controlled substance prescribing. So we can work with DEA on that.
Well, it is something that I'd like to explore with whomever is willing to work with us, because I look at this as an issue. We do some pretty extraordinary things with telehealth and how we dispense the controlled substances in a tightly regulated, controlled way. And we think that we've got the tools in place, but we do need to have some level of exemption or waiver option out there. So
Sure.
I'd really like to work with you. Dr. Collins.
If I may, I think this is another wonderful example of how our efforts to help those who are seeking treatment for addiction need to have a broader range of options than what currently is possible. But we need to be sure those options are evidence-based. And so what ultimately one would like to have is a sort of precision medicine approach to helping people who are addicted, so that you find the right treatment in the right situation at the right dose with the right kind of psychosocial support and the right MAT that works for that person. And obviously the answer to that's going to be very different for somebody who's in the bush in Alaska versus somebody who's in an urban center. NIH is very much interested in trying to contribute more evidence to those other options using our clinical trials network, and I think you've raised a very important issue that we should look at closely.
Well, I look forward to working with you on that. I do have a question about drugs over the internet, but I'll wait for the second round. Thank you, Mr. Chairman.